Good evening, everyone. Welcome. Those that are just coming in, welcome to our Zoom room. Thank you for joining us. For the doctor is in this evening. We will begin in a couple of minutes. Please just bear with us as we have people join us in our Zoom room. Thank you for being here with us this evening. Those that are just coming in, welcome. Thank you for joining us this evening. We're going to give a couple of moments for people to come in. I know that many people are coming off of other Zooms or finishing their family dinners on a Sunday evening, and so we want to give everyone the chance to be here for the beginning of the program. Thank you. We'll just wait one more moment and we will begin. Okay, good evening, everyone, and thank you for joining us for tonight's The Doctor is In, an update on the vaccine and on the state of our current pandemic, and who better to give us this kind of an update, and who better to share with us the knowledge in a clear and just really a way that no one else that most of us have heard has been able to do than Dr. Sarah Schlesinger Hirschfeld. And again, back here by popular demand, our very own Lenore Brachot, who will be moderating. We want to thank all of you for being here with us this evening. And as we do for each of our Zooms, we want to begin, and especially during a very heightened time, to offer our prayers, our tefillot, for a refuah shlema, a recovery for all those that are ill during this very difficult time period. We continue to hear of cases within our community, within the greater community, and certainly around the world. And we wish everyone a speedy recovery and a full recovery. And to those who have lost loved ones during this time period, we send you our condolences and we stand together with you. And we hope that this will end very soon. And I think that's what one of the focuses and one of the messages of the evening will be. In advance, we want to thank Dr. and Mrs. Fred and Mindy Miller for sponsoring this evening's Zoom in memory of Fred's mother, Hannah Miller, and the grandmother of Jeremy and Jared Miller. May her neshama have an aliyah. She has her yahrzeit this week, and we wish them all of the best. So this evening, we have, as I said, back by popular demand, Dr. Sarah Schlesinger Hirschfeld. She's currently the Associate Professor of Clinical Investigation at the Rockefeller University and the Chair of Institutional Review Board and Senior Physician at the Rockefeller University Hospital. And she has led several clinical efforts to bring new HIV vaccine candidates developed at Rockefeller into her clinic. And she's become very, very well known here in our community for helping us on so many levels and in so many ways, not just for these Zooms, but I can tell you how many people have been reaching out privately to Dr. Schlesinger Hirschfeld for her advice and her thoughts. But I continue to say that she is best known to us here in the Ramaz and KJ community for her adorable, special, and wonderful son, Jacob, who we adore, and we look forward to having back in school very soon. And she's joined this evening by the one and only Lenore Brachot, the chair of the Ramaz Science and Technology Department. Amazingly, Lenore has been at Ramaz for the past 14 years after graduating Cooper Union and then Columbia Graduate School. Lenore has really done an amazing job bringing the Ramaz Science Department into the day, if you will, and is doing so much amazing work and encouraging our students to grow in science and technology education. And again, she is well known for her three amazing children, Nadav, Amit, and Liana, who all are attending Ramaz. So it's wonderful to have you both here. We thank everyone for being here this evening. I want to remind you that tonight you could put any of the questions that you have into the Q&A, and we will share those questions directly with, and we'll get to as many of them as we can. We will share them, and Lenore Brachot will pose them to Dr. Schlesinger. Wishing you all the best, and thank you in advance, Dr. Schlesinger and Lenore Brachot.
Thank you so much for the intro, Kenny, and thank you for having me again. It's really an honor and a pleasure to moderate the discussion with Sarah Schlesinger Hirschfeld. And now that the vaccine is already being administered, it's a great time to have a focused discussion on the vaccine. I'm sure many of you know people who have received or are receiving this first round of the vaccine, and it's just a really exciting time. So I'm going to let Sarah start with an intro, and then I'll pose questions. And just a reminder, if you're just coming in, please submit questions through the Q&A so that I can pose them to Sarah.
Well, thank you, Kenny. Thank you for your kind intro. And it really is my honor to be able to help in some small way with understanding what's going on. As I say to so many people that, I've spent my life worrying about viruses and antiviral vaccines. Just ask my children. And it's not been all that interesting to most people, but it's having its moment now for sure. And the antiviral vaccines are certainly having their moment right now. And actually, Lenore, thank you so much for moderating. And Lenore and I were both supervising moms. I chaperone moms at the 4th grade lunch in Central Park, appropriately socially distanced. And we started chatting, and it occurred to, I think, both of us that the conversation deserved to go on longer, and probably people other than just the two of us would be interested in hearing what we were talking about. So this is an extension of that conversation in many ways. And, since we last talked, the last time we talked, the infection rates were low. We were gathering outside socially because it was warm and comfortable, and things really were starting to feel a little bit like normal. We are now back in a very dire circumstance. The infection rates around the country and around the world are higher than they've ever been. Every morning on the news, you hear that we've set another record for deaths, new infections, hospitalizations here and in Europe as well. It is nothing short of devastating. However, and not to minimize it, but unlike in the spring when this happened, the thing that's different, there are several things that are different. We know much more about the virus. My clinically active colleagues know much more about how to take care of people who become sick. But most important, there is a vaccine. There are several vaccines. And all along, I was saying, science is going to save us. There are going to be vaccines. They're going to be here. They're going to be here. And I almost didn't believe it myself. And the FDA had agreed that a vaccine that was what's called 50% effective, so partially effective, protect half the people who received it, would be adequate to approve under this very, very difficult circumstance. Those of us in the sort of in the vaccine world, we're hoping, I think, for something that would be 65 to 75% effective. And that was what I was thinking. And I've heard several people say the same thing. I don't think there was anybody who didn't cry when we learned that the Moderna and Pfizer RNA vaccines, so these are vaccines that are made of messenger RNA, no vaccine for a human being has ever been made this way before, are both 95% effective. So that is just the best news that we've had in the pandemic for a whole bunch of reasons. It's good for the individuals who receive the vaccine, but it's also really good for the community because vaccines work in two ways. They work to protect individuals, and then they also work, as you've probably heard about, herd immunity to protect the community at large. So the Pfizer vaccine, many of you may know people who've already received it. I've gotten questions from several of my students about it. We had a lovely email from our friend John Lieberman today that his son Evan, who's a radiology resident at Maimonides, received it without incident. There are lots of people who are getting it. I myself won't be getting it for a couple of weeks because I'm not a first-line healthcare worker, though I am ready to get whichever one they'll give me. And it's really nothing short of a Hanukkah miracle. And I've said this to my children who have rolled their eyes appropriately, but I always have these things that happen. I say, well, if I were going to write a Jewish children's book, it would be this story. And there are a variety of, family stories that seem engaging to me and probably not to too many other people. But the Pfizer vaccine truly is a Hanukkah miracle, in that in the darkest days of my life and probably everybody's life here, and I guess pretty much unless you lived through the Holocaust, on Hanukkah, there was a vaccine in less than a year. The common wisdom is, and I lecture on this, I have slides in my PowerPoint on this very computer that say it takes 10 years to develop a new vaccine from discovery to the first person whose arm it goes into as a clinical product. The shortest time in modern clinical development was in 1964. Maurice Hillman developed the measles vaccine. It took 4 years, and that was considered a record that would never be beaten. Now, in 9 months' time, we have 2, and we'll have a third vaccine quite soon, that went from an idea in somebody's head into the arms of millions of people in under a year. And that is nothing short of a miracle. But the fact that it arrived on Hanukkah, okay, that's a pretty good story. But the part that's amazing is that these vaccines are vialed. The Pfizer vaccines are vialed, 5 doses to a vial. So when they arrive at the place where they're going to be administered, in this case, the hospitals, they're thawed out, and the nurse or the doctor or the technician draws out with a syringe 5 doses from the vial. Well, it turns out there's always a little bit of an overfill because, if you drop a drop or something like that in a multi-dose vial, these were overfilled 20 to 40%. Many of the vials, rather than containing 5 doses, contain 7 doses. Some even contain 8. So that means that many more people can be vaccinated than was anticipated. And frankly, I've never heard of anything like that happening. And it just seems like, the miracle of the oil for modern times. So I doubt I'll ever get to write it. So if anybody listening would like to write it, I'm happy to consult. But it is a dark time right now. But there's light at the end of the tunnel. The problem is, the challenge for us is even though there's light, it's not over. Most people are not vaccinated. Most people are not going to be vaccinated in the next few weeks or months. It's going to be probably into the spring. And so until that time, we have to double down and do all the things that we know that work. Our masks, being socially distanced, washing our hands, testing, not going out if we're unwell. And none of them are easy, and everybody's tired. So, excuse me, this is not COVID, this is just talking too much. So that's my not very brief introduction.
Since you mentioned the timing, we know that Pfizer and Moderna are out now. What do you think the timing will be for the other vaccines? And when will it be available to the general public? So right now it's just to healthcare workers. You wanted to touch on the order of who would be receiving it.
Who's going to have the opportunity to get it. So the Pfizer vaccine was first. Moderna received the EUA, that's an emergency use authorization, from the US FDA on Friday. It shipped out today. I watched it on the news this morning. So the people will start getting it tomorrow and Tuesday. The AstraZeneca vaccine, which is sometimes known as the Oxford vaccine because it was invented at Oxford, which is a chimp coronavirus. It doesn't come from a chimp. It's a vector that targets chimp cells, so humans are not pre-immune to it. That one's just weeks away. And nobody knows until they announce that they're filing with the FDA exactly when it will be, because it's all based on events. These are all event driven. So the people in the trial, if you recall, are divided up. Let's, for argument's say, half and half. It's really, in these cases, more like 2/3 and 1/3. We'll say half and half for ease of thinking about it. Half get the vaccine, half get placebo. So salt water, but they get an injection. And nobody knows who that is, not the individuals involved, not the participants, not the physicians, nobody. It's called double blind. And then they wait and they see who gets COVID. They follow for who gets COVID. And so every so often, and I don't know if it's every week or every 3 days, depends on the trial design, there will be a look at, or no, not every 3 days, it's every week or every 2 weeks, where the infections are falling. Are they all falling in the placebo group, or there's some in the vaccinated group as well? And there's a predetermined number of infections that have to occur. And I don't know what that number is for the AstraZeneca vaccine. And when those numbers occur, when that number occurs, there will be a look to see that's when the data will be locked. They'll check to see if, hopefully 90+% of them occurred in the group that received placebo. And then the data will be sent to the regulatory agencies. But it's expected in the next few weeks. The Inovia vaccine and the Johnson & Johnson vaccine are also not far behind, just another matter of weeks. So that's why when people say there is a vaccine, there are many vaccines. And each of these are slightly different. In the interest of time, I'm not going to go over all the differences, but there's a really good article in the Times, which I can provide, that goes over the differences, but they all appear to be working. That's the very, very good news. And as they roll out, so it's a complicated endeavor. The CDC comes to recommendations for the states as to what the priorities are. So the CDC determines the broad priority. And they just met, I don't know if it was yesterday or today, but I just read in the paper that after the frontline healthcare workers, nursing home residents, and nursing home workers, the next groups that are going to be receiving the vaccine are individuals 65 and over and frontline workers. And frontline workers include grocery store workers, postal workers, first responders are in the first group, and teachers. So teachers will be receiving the vaccine in the next tranche. There has been and continues to be a big debate about whether or not it's most important to protect the people who are most likely to die or the people who are most likely to get infected and spread it. So, right, older people who are at home, who are protecting themselves, should they be next, or should it be the people who are out, who are less likely to contract severe disease and death, but could get very sick, could have long-term consequences, and don't have the ability to protect themselves with their behavior? So that's how the sort of discussion has gone. And it was just, the CDC just came out with these recommendations. But it's then down to the level of the states to determine how that actually happens. And, the execution is not trivial at all. It's really hard. And so, even with the vaccination of the healthcare workers, each hospital system was allocated a certain amount of vaccine, and then how it was allocated within the hospital systems was determined by the hospital systems. So, the priorities, again, broadly set, were the people at most risk. So people in the emergency room, people in the ICUs, people in the COVID care units. And when I say people, and I think this was a tremendously fine ethical decision that upon which everybody agreed, was that doctors, nurses, ward clerks, cleaning staff, dietary aides, anybody who worked in those areas would receive the vaccines. And then go from there. I happen to know, because I've gotten questions from them, some of the young physicians in my program who are not directly involved in the care of COVID patients or received it over this weekend. My assumption is that there was enough left over, and they went to the whole house staff. So the house staff are the young doctors working in the hospitals, figuring that they rotate in and out and they may get called upon if things get more difficult to take care of COVID patients, even if they're not caring for them now. But I wasn't privy to those decisions.
Okay, and there's a question of asking if you can address the difference between the two vaccines. And someone also asked, which vaccine should we choose if we have a choice?
Well, first of all, the biggest problem you should have in your life is to have a choice between the vaccines. And unless you have an allergy to any specific, to a specific molecule in any of them, I don't see any reason to choose any of one over the other. I particularly like the Moderna vaccine because the Pfizer vaccine, so the Moderna vaccine and the Pfizer vaccine are very similar, very similar. They both use messenger RNA. The sequence or the actual information is slightly different, but there's, in my view, there's no significant difference there. The person who happened to make the sequence for the Moderna vaccine is an old friend of mine, and I like that. And the Moderna vaccine uses a different lipid bilayer to hold the RNA, which is what both of them use. It doesn't require the very, very cold freezers. So you've probably seen all of this on the news, that the Pfizer vaccine requires being kept at -80, which is the, in a laboratory, it's a standard thing, but in real life, it's a very rare thing. It's very, very, very cold. The Moderna vaccine doesn't have the same requirement. And so I prefer it for that reason. That doesn't have any impact on any individual. If, in New York, there are lots of -80 freezers, so it's not an issue. But the Moderna vaccine can be more readily deployed around the world. So I prefer it for that reason, but it has nothing to do with anything that would have anything to do with any of the other, any personal decision. The AstraZeneca vaccine is an adenoviral vector, which is very safe. People have hypothesized that immunity may last longer, but there's no real data on that. So I have to tell you, I think it's unlikely at this point that anybody's going to be given a choice, because it's kind of going to be tremendously opportunistic. I would take what you could get first. What's very important to know is getting one vaccine does not prevent you from getting another one down the road. Okay, they're not, they don't interact in any bad way. They can be used one after the next. And there's no requirement, which I think is interesting. There's no screening for people who have pre-existing antibodies or who've had pre-existing COVID infection. Both groups were included in the clinical trial, and it's safe for both of them to receive the vaccine.
Were the side effects different?
No,
for people who've had it? No,
I don't believe so. It is possible that somebody would have, more of a reaction if they had a pre-existing immune response, but I haven't seen that published. I haven't seen data on it.
And how long does it take for the vaccine to go into effect? How long after the first dose do you need the second? Why are there 2 doses?
All great questions. It takes 2 weeks to mount a full immune response. It starts to kick in about a week. 2 weeks, you've got the peak of an antibody response. So 2 weeks from the first shot, you start to really have a response. Another one of the sort of miraculous things is, even though both of these vaccines have been approved for 2 doses, there is good immunity after 1 dose. That's been reported with both of them in the clinical trials. Now, this again is a bit of a controversy, because there are those who might say, well, if you get good immunity with only 1 dose, why wouldn't you vaccinate double the number of people? And that's partially because of the way the whole process works. And that is, you have to do what you say you're going to do. This is what you tested. This is what you supported in your clinical trial. And that's what you have to do. You can't start, as most of us scientists like to do, getting creative and going off and saying, well, this looks good, let's try that. You're bound by what you said you would do. However, I think that people will have, there's no doubt most people will have a robust immune response 2 weeks after the first injection. There's 3 weeks between the 2 injections for the Pfizer vaccine and 4 weeks for Moderna. It's called a prime boost strategy. And even if you have a response to the first one, the second one will make it more durable. And that's one of the reasons that people are saying it's important to go ahead with both of them. In any case, everybody's going to anyway. But if you were to happen to just get one, you would start to have some protection after 2 weeks. So 2 weeks after the second shot, whether it's 3 weeks or 4 weeks, or if you were somehow unable to get there and you got it in 5 weeks. So 2 weeks after the second shot will be peak of immunity. And the thing that's important to remember is that you're protected from getting infected or significantly infected, from getting sick. And both vaccines really prevent from severe disease and death, which is really what everybody wants to avoid. It has been demonstrated with the Moderna vaccine that it also prevents you from spreading to others. That doesn't mean that the Pfizer vaccine doesn't. It just means those experiments haven't been done yet. My strong belief is, and you can quote me on this, but it is just a guess, is the Pfizer vaccine will have the same effect. So that once you become immune, it's possible for the coronavirus to replicate in your nose at low levels, even if you've been immune, whether from natural infection or from a vaccine. But the likelihood that you'll get real high levels and enough to spread, it's probably not so much. But because it's not sure, you still have to wear a mask after you've had the vaccine, because you could still infect others and you're wearing it to protect others.
Thank you. You just answered someone else's question. And a lot of people are asking about new strains. If you read about what happened in the UK, and will the vaccines continue to be effective against these new strains?
Well, this is the $100,000 question, right? The $1 million question. So, I was preparing for this. I had spoken to Kenny and Lenore, and I touched base, and I was getting all my ducks in a row. And then I opened the paper this morning and I read about the new isolates from the UK. On the one hand, it's not surprising. Viruses mutate. That's what they do. The data from the UK is worrisome, but it is not dispositive. I've heard on like every news report that I've had on all day that it's 70% more transmissible. That's in modeling studies. That's not actually data from life. That's what they're hypothesizing. And most viruses mutate to become more transmissible, but less virulent. And there's no evidence that this strain is more virulent. Quite the contrary, it might be less virulent. So when a new virus emerges, that's what a virus wants to do. A virus doesn't want to kill its host, because then the virus loses its host. A virus wants to keep the host alive a long time. So it is adaptive for the virus to spread better, but be, as I said, less virulent. It's not clear that that's the case with this, but it certainly doesn't appear that it's more virulent. So this isn't the first time these changes have been detected. You might have read about them killing all the minks in Denmark. So in Denmark, coronaviruses naturally infect weasels. So ferrets are used for experiments. Ferrets are kind of weasels. I didn't know this, but so are minks. And so they detected this coronavirus in the mink population, and it had this mutation, and they were afraid that it would mutate to not be susceptible to the vaccines. So they killed all the minks. I think they overreacted a little bit. There's no reason to suspect that this particular mutation will make the virus resistant. And in general, and this was my own thought, and then I've read several articles that have confirmed this, these single mutations, it's not an on-off switch. It's very unlikely that there could be a single mutation that would change the receptor binding protein sufficiently to make it not sensitive to the vaccine. Over years, the virus may mutate and become not sensitive to the current vaccine, in which case we'll make a new vaccine. But in this round, it's very unlikely. This is different from flu. So all viruses mutate. Flu mutates to the greatest degree because flu undergoes two sort of forms of mutation. One is called antigenic shift, which is different from other viruses. And that means there are whole cassettes of genetic information that move around. The other is called antigenic drift, and that's what this and other viruses do. And the measles virus, for whatever reason, tends to be a very stable virus, and I don't believe that vaccine has changed in 30 or 40 or 50 years. But this one may have to. We may have to make new vaccine strains as the virus continues to evolve, which it will no doubt do. So, we're going to have to keep following this and correlating the genetics of the virus to its clinical behavior.
Okay. And just reminding everyone to please submit questions to the Q&A if you have any questions. There are a bunch of questions about allergies.
Right.
If people have egg allergies, they usually have a different vaccine. For the flu, would it be the same here? And also, is it safe for pregnant women?
Okay, so is the virus safe for pregnant women? And I actually got an email question about that. It is generally considered safe for pregnant women. It has been approved, under the EUA, but any pregnant woman has to talk to her doctor. I'm very careful that I don't want to be giving anybody medical advice. It's certainly not this way, but even one-to-one, I'm not a practicing physician, and you need to ask your either your doctor or your midwife. because it's all of these decisions are risk decisions. So I had one of my junior colleagues, a lovely and very, very talented, capable young doctor, call me Thursday night that she'd gotten a call from the hospital at which she works that they had a dose of vaccine for her for Friday morning. And she just wanted to check with me. She knew she should get it. She wanted to check with me about whether I thought it was safe. And, you know, I told, because there had just been these 2 reports of the severe allergic reactions. And I said, you know, if you have a history of anaphylaxis, which is the horrible allergic reaction where you require epinephrine, then you shouldn't get it. But unless you have that, I would go ahead and get it. Because all of these are risk analyses, right? We're thinking, what is the risk of this versus the benefit? And what is the risk of this versus the benefit? And there are times when you don't want to take a vaccine for something that's very rare if the vaccine is has a lot of side effects. The yellow fever vaccine is a perfect example of that. The yellow fever vaccine is an extraordinarily good vaccine for a whole bunch of reasons, which I could discuss with anybody who's interested. But it has a fair number of serious side effects and causes death in some number of people. So you only get it if you need it. If you're going to go to travel to an area where there's yellow fever that's endemic, or you work with it in a laboratory, it's not given generally because the risk-benefit analysis for somebody who lives in the US just isn't there. But in this case, with what's going on with the pandemic, in my view, there's just very little question that the vaccine is safe. The one exception, which you asked about, are people who have a history of allergies. If you have a history of anaphylaxis to an injected medication, you should not get the Pfizer vaccine. That's the current recommendation by everybody I've read, and I would strongly agree with that. Egg allergies are important for the flu vaccine because the flu vaccine is made in eggs, literally made in eggs. Now that is a 1950s technology. You might say, why are we still having a vaccine using that technology? Again, a story for another day, but it's really because it's grandfathered in from a regulatory perspective. These vaccines are made in the most modern way, and they're made out of synthetic RNA. But that all of those materials come from something. They don't come from eggs. So egg allergies don't apply. I don't know offhand the ingredients in all of them, but if one has allergies, you can find that they're online, what the ingredients are. If you are allergic to an ingredient, you shouldn't receive it. But if you're not, I would go ahead. The thing that I can tell you that's reassuring is everybody who's administering these vaccines is acutely aware of the worry of anaphylaxis. These are not long-term complications. These are, you get the vaccine and, you know, within moments or minutes, you're quite ill. And everybody who's doing it is prepared to treat it. These are not being administered in tents. They're not being administered, you know, out on First Avenue. They're being administered in healthcare facilities for now. It's going to be interesting to see what happens as the vaccines continue to roll out. And certainly if you have a history of a lot of allergies, you know, food allergies, respiratory allergies, I would make sure down the road that when you receive the vaccine, you receive it in a real medical facility. So if you do have a problem, they know what to do.
And how long will the immunity last? Will people need to take this vaccine every year, like the flu shot?
Nobody knows. That's a super good question. My own guess is it's going to last longer than the flu shot. It's a much better vaccine for a bunch of reasons. It's unlikely to last forever. You know, so whether it's going to be every 3 years or every year, or you know, my guess from a public health point of view, it's going to be every year for a while because we come in for our flu shots, and so it's just an easy sort of routine to maintain. But it's yet to be seen how long the immunity lasts. But, you know, the other thing is that it's going to vary based on how much virus is circulating. Because if you've been immunized and then you come in contact with the virus, that boosts your immunity. It acts as a booster. So if, you know, you were to go out now unmasked after having, you know, waited a month after receiving the vaccine, you'd be being boosted every time you encountered somebody with with COVID. So it will not only change with the vaccines, it will change as the virus becomes less prevalent.
Okay. And someone asked, how can we know that the vaccine is safe long-term if there was not enough time for a long study?
We don't know. We don't know. It's a good question.
We also don't know the long-term effects of COVID.
We don't know the long-term effects of COVID. Yeah, absolutely. then that's why I say it's a risk analysis, right? We don't know the long-term effects. There's no reason to think that the long-term effects of these vaccines are going to be based on the technology used. There's nothing about them that lingers in the body. Let's put it that way. I heard a very good description that the RNA is like the information. It's like the code, and it gets into the cell, programs the cell, and then is gone. RNA is exquisitely sensitive to enzymes called RNases, which are everywhere. It's very, very hard to work with in the laboratory. You have to like wash your glass there with acid, and you have to wear like regular PPE because if you breathe, you destroy it. So it's not going to linger in your body. Longer term studies have been done with animals, and there don't seem to be ill effects, but we don't know. We've only known about this virus for less than a year, so we don't know about the vaccine either.
And there are a few questions about children. Do we know when children will be eligible for the vaccine? Because I know they weren't really part of any of the trials. How it will impact schools?
Right. So that's obviously a very good question. Currently, Pfizer is testing children 12 to 16 and Moderna 14 to 16, I think. I could be wrong about that. I could have it reversed. What they're doing, and this is typically what's done, is they're kind of inching down. There's as most of you know, children don't tend to get very sick, except for children who have, very serious underlying conditions, which is, one of the blessings of this. The people in schools who've been getting sick are the teachers and the staff. And so I think that's appropriately why they'll be amongst the first to receive the vaccine. My own guess, and this is just a guess, it won't be till next year, because the combination of the fact that it takes a long time to test in children, that children generally don't get terribly sick, and the timing, I would guess it will be next year, but that's just a guess.
Okay. There are a few questions again about people who have antibodies. I know you talked about this already, but maybe you can touch on it again. People are asking, if you have antibodies and get the vaccine, what happens? And will priority be given to those who haven't had COVID yet?
So that the priority is not being given to those who haven't had COVID yet, which is interesting to me, because if one were asking me to design priorities, I would do it that way. I think that's for two reasons. I think part of it is because we don't really know about the immunity that COVID induces. It's not clear. It appears that though you can theoretically get it reinfected, it's a rare event. And when people do get reinfected with a different strain, they don't get severe disease or die. The last paper I read on this was now a few weeks ago, so there are no doubt more. There were 5 cases described on a molecular level where they'd really done the sequencing of reinfection. And 2 of them were in very seriously ill people, one who had cancer and chemotherapy, and the other had an underlying immunodeficiency. One of them got severe disease and survived, and the other died. The other 3 people were picked up in random testing and were not ill or were very mildly ill, like they had a sniffle. So my guess is that that's pretty much, how it's going to go, that you will be able to get reinfected, but you won't really get sick, that you get protected from severe disease and death by that initial infection. But because we don't know, and because the data isn't there, there wasn't a decision made. The other reason is it is already a logistical nightmare to vaccinate everybody. An absolute, tremendous operational challenge. So to add any other distinction onto how people are selected would make it harder. And an example from this is, I know when I worked in the hospital with chickenpox epidemic, you can easily get titer. We easily have your chickenpox antibody measured, either from, and this was before there was a vaccine. No, there was a vaccine. There was a vaccine, but not. It was a fairly new vaccine, and there was an outbreak of chickenpox in the hospital. So I had a baby, and when I had my baby, I had all those titers measured. As anybody who's had a baby remembers, they measure those because they want to give you a vaccine if you're not immune. So they checked me and they said I didn't have to get vaccinated because I had a good titer in the last couple of years. But if you didn't have it on file, they weren't going to test you because they didn't have the the bandwidth logistically to draw blood, have you come back in 2 weeks, wait and see, or whatever it was. They just vaccinated everybody because there's no harm in being vaccinated if you have pre-existing antibodies. It just boosts your previous immune response. So if you have a previous response from a known illness, or just you've come up positive, you will get boosted by the vaccine. And the reason why it is in your own advantage to have it is it may give you a broader immune response than that which you have from natural infection, and may in fact be more protective. That's what's being published. I'm not convinced that it is more protective myself. I haven't seen data that it is, but we just don't know.
Someone asked if you can receive the vaccine from both suppliers. And I was thinking the same thing. Are they keeping track of which vaccine you get? Can you get the booster of a different one?
I have no idea how they're keeping track of all this. I think it must be an absolute nightmare myself. I know they're going to try, because I had heard some discussion about at some point the CDC wanted to collect sort of citizenship data, and then that was a decision was made that that was not an appropriate thing to do. But there's no reason immunologically why you couldn't get more than one vaccine. I don't think there would be any ill effect, but I wouldn't recommend it, because I don't think you don't need it, and it would waste a second dose.
And once there is different, now both of the vaccines are mRNA vaccines, but once there's different types, would it be harmful to have both?
No.
Okay.
No. The data, I say that based on historical data. The data doesn't actually exist, but there's no reason to think so. And yeah, I think that the reality is that that's going to happen. And certainly, there's a very good historical example of that. So you're too young to remember this, Lenore, and I'm actually too young to remember it too, but just by a tiny bit. The polio vaccine, the first polio vaccine that was developed was the Salk vaccine. And I think polio, for those of you who remember, was at least as devastating as this is in many ways, when in the summers when it erupted, because it struck children. So, your kid would come home from school and come home from camp or playing and say they didn't feel well, and then they would be dead or paralyzed the next morning. I can't even imagine. But the Salk vaccine was introduced in 1955, and it's a whole killed virus vaccine, and it's injectable. And everybody who could get it got it. And that immunity wasn't so durable. It only lasted a few years. But a year and a half later, the Sabin vaccine was approved, and that's the live attenuated vaccine, the little drops. Most of you remember. Now they've gone back to the Salk vaccine, but most adults, I think, received the oral vaccine, either in drops or on a sugar cube. And that was a much more durable vaccine. And everybody who received the Salk vaccine then received the Sabin vaccine. My eldest children, who are about to be 33 and about to be 31, received the Sabin vaccine, which was the drops. My children who are about to be 26 and about to be 28 received the injectable vaccine first, and then the drops, as if, like what happened when the vaccines were introduced. And then Jacob has just received the injectable. The vaccine policies have changed, but there's no safety issue mixing it up that way.
Okay. And there's a few questions about how people will know when it's their turn to get the vaccine, and where will it be accessible?
Yeah, I wish I knew. That's not my area of expertise, and I don't think anybody really knows. I know from a friend of mine, Dina Prop, who works in communications at Hospital Cornell. She said that they've asked people not to come and ask because they don't have it for anybody but the healthcare workers for now. My guess is there'll be public service campaigns and it will be on the news, but I would check with your doctor, because doctors' offices will either have it or they will be referring their patients to healthcare systems with which they are affiliated. And so if you have a physician, that would be the first place I would start. For people who are employed, like I get notes about my vaccines from my employer, and some people will learn that way.
There's a question that what happens if the vaccine isn't stored properly?
It doesn't work. It doesn't work. It falls apart. So the DNA, the RNA is like like a chain. It's like a little, think of it as beads on a string, but it probably forms like a loop. And then it has the lippet around it to hold it into like a little, think of it as a bead. And if it gets warm, it just falls apart and it won't work.
Okay. And are they working on an oral vaccine?
Not that I'm aware of. You know, I'm a great fan of oral and intranasal vaccines for a whole bunch of reasons. And for coronavirus, an intranasal vaccine would seem like a particularly appropriate route of administration because so much of the action is in the nasal mucosa and the upper respiratory tract. I'm sure somebody's working on it, but I haven't read about it.
And there's a question. If you have an elderly parent who receives the vaccine before the rest of the family, can the family safely visit with them?
You know, that's a very good question. And the answer is will be safer for sure. The problem is that older people don't make protective immunity as well as younger people. On the very good side, these vaccines have performed very well in older people. They've been tested in older people. So it would certainly be safer, but I would recommend personally still wearing a mask. You know, I mean, we're still going to have to wear a mask. We're still going to have to keep our distance until we see things go down. You know, as things start to go down, you know, it's not going to be, you know, how it was like in the spring where a light sort of switched on and all of a sudden we had to do all these things. It's not going to be like that. What's going to happen is people are going to start to get vaccinated. They're going to start to get immune. We still have to do all the things that we've been doing, but hopefully that will be, you know, it's one more of these layers. You know, I've talked before about the notion of harm reduction model. So no single thing is perfect, but when you put a bunch of layers that it's like, you know, layers of Swiss cheese with holes, if you layer them one on top of the other, you can get a pretty good coverage of your bread. And there was a lovely article in the New York Times, which I think Leah, who's helped us, shared in advance, and I guess she'll share afterward. It has really good graphics on that. Well, by far, the vaccine is the best, the least holy of the layers. But for a while, I would still wear a mask. I mean, as you who've listened, as everybody who's listened before, my mother is 85 or about to be. And, you know, I went to see her today. We sat on folding chairs in her garage with the garage thing opened, which in our coats with our masks on 6 feet apart. Now, it's always lovely to see her, but you can imagine that that was not the most pleasant visit we've ever had. You know, when it was nice out in the summer, we sat in her backyard in our chairs 6 feet apart with our masks on, and it was very lovely. You know, at what point we'll move our chairs closer or be inside, I'm not entirely sure. But once she gets vaccinated, you know, then we'll start to think about that. But it's going to be a gradual process, I think.
There actually are a few questions about mask wearing after being vaccinated, which I know you touched on, but maybe you want to repeat.
Do you want to ask the specific questions or do you just want me to talk about it?
It's mostly people ask after getting the vaccine, how long do we need to wear our mask?
Well, the answer to all this is nobody really knows. But out of an abundance of caution, you certainly need to wear your mask until 2 weeks after your second vaccination, right? So if the vaccines are 3 weeks apart or 4 weeks apart, and then you get a second shot, and then there's 2 weeks after, you need to do everything exactly as you're doing it until that time, even though it's very likely that you'll have some level of protection. Nobody knows that's the problem, but my own guess, or my own sort of well-informed guess, so what's going to happen is the rates are going to start to go down, and everybody's going to start to feel a little safer. And then we're going to inch closer and inch our masks down and, you know, sit at a table 6 feet apart outside without the masks, and things will be okay. And then we'll do the next thing. And my own guess is that by, I keep saying to my beloved husband, I'm planning our Passover Seder in my head. You know, I've missed so many of our, you know, we're really very fortunate. We have a large extended family who were all close, though some of them have now moved away. They have to camp because of COVID. One of my sons moved to California, but you know, having everybody back around the same table is, obviously really important to me and probably to many of you. And I keep thinking Passover, maybe Passover. And then if I'm in a negative mood, I think, well, it'll be Shavuos. But I think somewhere between Passover and Shavuos will be good. It's going to take till then. Things will be better before then. It's not going to be Purim. Okay, we're not going to have regular Purim this year, I don't think. But I'm thinking Passover.
That's wishful thinking. I'm
It-
hopeful.
It is hopeful thinking. I think Shavuos is more realistic, but but that's not so far away, right? It's not so far away. So that gets, to the other thing that we were talking about is that, this is the light at the end of the tunnel, but it's still really bleak out there. And we have to double down in this last interval on our mask wearing, our social distancing, our hand washing, our getting tested, which now is available, which is a good thing. And, I know that the break is coming up and there are people who are going to travel. My own strong recommendation is not to. Everybody who asks me, I keep saying I wouldn't. But if you're going to, the important thing is to be as safe as possible and to comply with the quarantining and testing to make sure that you're not, like I just read this article in the paper about some United Airlines flight where somebody died and it turned out he knew he was COVID infected. He got on the plane anyway. If you are not well, you have to stay home. I mean, that's absolutely essential. And you have to follow all the quarantine rules and all of the testing out of quarantine rules if that's what you opt to do for now. Um, I want to go to Miami as much as the next person, and my husband wants to go skiing more than the next person, but it's just not a good idea to do it now in my own view. But this really is not going to pass. It's passing before our eyes, and I'm always reminded of World War One ended on the 11th hour of the 11th day of the 11th month. And that's why we have Veterans Day in November. But for some reason, I've never understood the powers that be told the soldiers to keep fighting on the 10th until the bell tolled on the 11th. So the armistice had been agreed upon. Everybody knew the war was over, but they kept fighting that last day. Still will never understand that. But people died in that last day, and they were as dead as the people who died in the middle of a war. We've all heard accounts of people who survived to be liberated from Auschwitz and then died of typhus or malnutrition or refeeding, after the liberation of the camps. We're all so tired of this, me included, and we really want it to be over, but it's not over yet. And the infection rates are going up. And that means that you're more likely to get infected by being out and around. And, we've heard of several people who we know in our community who have gotten very sick. And so we really do need to be extra careful with these masks, get vaccinated, and then wait the full, 7 weeks, and then, start to pull back, then start to get rid of these. I have a feeling just when I get the system of keeping them organized in place will be when we don't need them anymore. But for right now, we still need them very badly. I heard a statistic on the news today that every 30 minutes in Los Angeles, somebody's dying. And more people have already died than died in Americans than died in World War II. In battle. It's just, it is beyond comprehension. And, we can only use the tools we have at hand right now. And it's going to take a while to get the vaccines all rolled out. And it's going to be bumpy. It's a logistic. I think they're going to use a lot of the organizational stuff that they use for testing. But as hard as that was to get going, this is a harder thing to do because the people all have to come back. It's a more invasive thing to get an injection. It's huge challenges.
Yeah. There's a few final questions.
Sure.
A good question. Can we reach herd immunity without vaccinating children under 16? If so, do we need to vaccinate children?
That's a really good question, and I don't know the answer. My suspicion is we probably do need to go under 16. I know that the Pfizer vaccine is being tested in children as young as 12. I think the question is more, do we need to go to children like under 3? And that I don't know. And particularly because those children, the younger ones particularly, I mean, there seems to be an inflection point at the age of 10 in terms of being able to really transmit it vigorously. I don't know the answer to that. I'm not sure that anybody does. And I think that that's a question that needs to be answered.
And has the vaccine been tested on immunocompromised people?
It's been tested on some immunocompromised people and not others. And I don't remember which one was which, right? So it all depends on, in the trials, who they included in the trial participants. And I know when they moved into the phase 3, which is the really large one, they included some immunocompromised people in both the Moderna and in the Pfizer trial, but I don't remember which categories of immunocompromised people. But you could find it out. I mean, it's published, and if you have, and again, this is the sort of thing where you need to consult with your own physician about your own circumstances.
And someone asked if masks are more effective than the vaccine.
Are masks more effective than the vaccine? That's a really good question, and it's an interesting theoretical question. My guess is that masks, if properly worn all the time, are as effective as the vaccine. But that's a huge if. It's like in contraceptive research, there is the theoretical, statistic. This method should prevent pregnancy 90+% of the time. And then there's the actual when in use. Because in use, when you're a human being, whether you're trying to protect yourself from whichever virus you're trying to protect yourself, or you're trying to prevent pregnancy, how you actually use a technology you have to use every time is very different from an injectable vaccine. And that's why vaccines are considered the holy grail of public health, because the best vaccines, like the smallpox vaccine, you get once and you're done. You never have to see that person again. They never have to think about it again. They never have to do anything again. Unlike a pill, unlike a medication that you might have to take every day. People are very bad at taking a pill every day. There's all kinds of examples of that. So I think theoretically they're probably equivalent, but practically the vaccine's going to win every time.
Okay, and for the last question, it's very uplifting thinking of Pesach and thinking of Miami. Will it be safe for there to be a Passover program where everyone has been vaccinated?
Well, that raises it's a real possibility. And that raises another question that again, I've said from the beginning, I like to stay in my lane, and this falls out of my lane, but others in the community who think more about these things, both legal and sort of operational, people are talking about not an immunity passport, but a vaccine card, to demonstrate that you've actually been vaccinated. And those have been used in the past. They've been used for smallpox. I think they're still in use for yellow fever. Now it's probably electronically linked to your passport. But when I was younger, there was a yellow card that, was issued by, I don't know if it was issued by the State Department or the Health Department or whoever issued it, and it was signed and dated, and you had it in your passport to show that you had been vaccinated against yellow fever. And I will tell you, I wouldn't be going to a Passover program with people who weren't vaccinated. So I think if somebody's organizing a Passover program, it's a good thing to think about. I'm sure there are civil liberty issues about that, but right now they're not top of my thinking right now, but certainly somebody needs to be thinking about them. But it's a good idea. As you know, certainly as well or better than I do, the state requires children to be vaccinated for a whole host of things to attend school. And that's how a lot of vaccinations are required. This will no doubt be the same when it gets approved for that group. But it's going to be interesting to see what happens between now and then.
I think we want to wrap up. Is there any final thing that you want to say to everyone?
Just thank you very much for listening to me again. It really is a miracle, but I think it was Ruth Gaffney, and forgive me if I'm misquoting the inspiring person from Ramaz KJ who sent this, but she sent in one of somebody sent us one of the Hanukkah writings about how it is incumbent upon to make our own miracles. And I think that's really, that's really the message right now is that we just have to do the hard work to get through this safely, because the end is in sight. It really is. And whether it's Pesach or Shavuos, that's really close. So wear your mask. Thank you very much. Happy New Year to everybody.
Dr. Sarah, thank you. Lenore, thank you. It's apologies. We had over almost 90 questions in the Q&A, and I know that we got to many of them. We sorted through them. To those that we didn't get to, we are happy to share some of those questions with Dr. Sarah Schlesinger, and she's always very happy and open, being as helpful as she can be. We really appreciate so many of you coming on tonight, and just remind you that tomorrow night we have an amazing program. At 8 o'clock, we will have 7 of the 9 Ramaz alumni who have clerked for Supreme Court justices over the years in conversation with Dr. John Jacoby. It should prove to be a fascinating evening, and it is a wide range of years stemming from the early 80s all the way up and through the 2000s. Alumni, many of whom are part of the KJ community on top of being Ramaz alumni. And really, it should prove, as I say, to be a fascinating evening and another opportunity to have during the COVID time period something very unique and different. We wish everyone, again, health and safety. And please continue to join us as a community, continue to support all the things that we're doing. And we are here with you and for you. Don't ever hesitate to reach out if in any way we can be helpful to you. Wishing you all a very wonderful night, and thank you for joining us.
Thank you. Bye.
Thank you.